Vanati, the IGO editor, Dr. Arup, one of the most prolific cataract surgeons in India, Dr. Kaushik, he's a big man in ophthalmology, heads the Shankara Eye Group. I'm Dr.Sreeni Edakhlon, and we have Dr. Umesh. Dr. Prabhu Shankar was supposed to present the first topic. He unfortunately could not come, so I'll be doing his presentation. So this is, can you play the video, please? This was a case of phacoemulsification, absolutely uneventful. There was nothing wrong till at the end of the phacoemulsification, the iris started coming out, the eyeball became hard, and the AC became extremely shallow. See, the iris is out, but I could somehow pull back the iris that had come out, but the eye was not taking in any more OVD. So there's no space in the antechamber, and the ball is hard. So I've had a few cases like this before this particular case. So what I did in those cases, 2 cases, I gave IV mannitol and took up the case after about 1 hour, and I could implant the intraocular lens in that case. 2 cases I had, in fact, postponed and did the IOL implantation comfortably after 2 days. So there are 2 possibilities in this. One is suprachoroidal hemorrhage, which was ruled out in this case and all the other cases I mentioned. The other possibility is that the fluid has got misdirected and it has gone through the zonules into the potential space between the posterior chamber and the anterior hyalod. That's a potential space called the Berger space. So probably why I'm getting more than normal of these hard eyes is probably because I do the surgery with a very high bottle height. So when the bottle height is very high, or if you are doing surgery with high IOP, there is a higher chance that it goes in. So what next to do? Before I show what I did in that case, I'll just show you one more case, similar case. So I became hard, AC was shallow, iris didn't actually come out. So what I did was closed it, took the patient to the preparation room, gave IV mannitol. Then after that, I became reasonably soft, and visco went in. AC became decently deep. I can't postpone it now. So I put in the IOL. See, still the PC has not really gone down. So it's a rigid hydrophobic foldable intraocular lens, and I could manage to put the leading haptic into the back, but the trailing haptic was a big issue here. See, if you try to force the IOL, try to rotate it forcefully into the back with this rigid IOL and the PC up there, 100% you're going to get a PCR. So you have to be really careful. Don't really try to rotate. So what I did was I tried to be as gentle as possible, and somehow I could actually nudge the trailing haptic into the bag. So I actually tried to rotate a little bit, but then I realized it's going to be dangerous. So the haptic went in. So it was not a very comfortable surgery as such, and not really sure it has really gone into the bag. So let's see what was done in the other case. So what was done was, with a 26G needle through the plas plana, went in to direct it basically to the Berger space, so just behind the PC, and went and aspirated the fluid. See, here the attempt is to aspirate the fluid, not the vitreous. So once the fluid comes out, immediately the eyeball becomes soft, and see the AC deepens, enough OVD goes in, eye is soft. So now you can implant the IOL inside comfortably. So the leading haptic goes in, you can comfortably dial the IOL into the bag. You can do aspiration properly. I could even go behind the IOL and aspirate the visco from there. See here, the attempt is to aspirate the BSS. So if you go more posteriorly, you'll be aspirating vitreous and cause vitreous traction. But with a small gauge, 26 or even lesser gauge, I mean, it doesn't actually, vitreous doesn't come into that. But so another option could be to do a small gauge vitrectomy. I'll come to that. So this is a case of acute intraoperative rock hard eye syndrome or acute fluid misdirection syndrome or subcapsular fluid entrapment. So this is what was done. Then I've done some literature search, and if you see this article by Gisbowski et al., he analyzed 55 articles from 1951 to 2016. And one of the observations he made is that vitreous decompression is required in these cases. And this study by Oliver C.F. et al. He studied many cases of in which pars plana needle aspiration was done, and said it's an extremely safe technique with no complications as such. So this is another case. Same thing happened. So it's happening quite frequently for me. So it went through the pars plana. Again, so you're not going posteriorly. The attempt is to go to the space just behind the PC and aspirate the fluid. So you don't need to aspirate also. Just keep it, the fluid comes out if it is the fluid that you have hit. So again, it goes back and IOL can be implanted very comfortably. So I'm not telling that this is the choice, but so many people, like I've made this presentation in a few other places. Some people have actually, we had such a case last week, and I struggled, and also, and when I make the presentation, I'm really scared that the VR surgeons will rape me, but I've talked to them and they said, it's okay, Sreeni, you can do it, we'll manage whatever is here. So, thank you.
Sreeni, that was very nice. But one other way also, what we tried in a couple of cases was just use the pars plana port. Just make a port, no need to aspirate also. The fluid is there by, it just walks out, it just falls out, so that is more than sufficient. In a couple of cases, we have done that.
Yeah, so I think this aspiration, okay, he's going. Hi, Sreeni. Sometimes some of the surgeons in the beginning only, we do it in therapeutic in optical keratoplasty, but I mean it's not really advisable. They do aspirate a little amount of vitreous, like we do if you're giving a intravitreal. Again, as you say, it's not an advocated methodology, but when it comes worse comes to worse, you can't postpone your surgery. You will have to do it. But then I think the precaution there is you ensure that the blood pressure is under good control here. Do not do it if they are hypertensive. Do not do it if you are expecting age-related arteriosclerosis, atherosclerosis, because in those patients you might have the danger of having a choroidal.
There is a case of relative anterior nanophthalmos. That is basically the axial length of the eyeball is normal, but there is a crowding of the AC. So there is a case study where the surgeon marked blindly do the vitrectomy, make a pars plana port, and mark the cutter, how much you go, and make a 4-5 second vitrectomy, make the eyeball soft, and go for the rexis. But sometimes it's very difficult. AC is shallow, cataract is intumescent. Maybe the patient having 29 diopter lens, then Rex is made really difficult. You cannot lose the Rex 6. You have to implant the IOL in the back. In that case, you can do, but yes, you should keep these options very limited last cases.
Thank you, Dr. Sreeni. I think we've been doing this year on year, and my topic will be repeated iris touch during phaco. And what is that next? I'm sure most of you who are doing phaco have at some point of time got this problem, and you know what the iris is going to do you. It is not going to leave you. It is going to follow you, irritate you, and make your life miserable. So that, so what exactly? So that's it. Now once you touch, you're done. The iris is always going to come to you all the time, and until you go out, and sometimes you feel like as if you just cut off the iris and go ahead with the surgery, especially if it is subincisional. So what are the causes? The main causes are again, especially beginners not respecting the central safe zone. When I mean central safe zone, the idea of central safe zone is the definition is clear for all of us, but when we go inside, we forget that simple fact that apart from irrigation, any aspiration phaco should be done in the central safe zone, not beyond the central safe zone. If it is a small people, obviously in IFIS, and high fluidic dynamics, and in case of surge, that is what exactly happened there. So what do we need to do? What do we need to do? We need to reduce the fluidics the moment you have that. Ensure that you respect the central safe zone and the aspiration port away from the iris. And you can use the second instrument if you are good, but as beginners, if anybody beginner is there, it becomes tough. Then iris hook or some rings might definitely be of some help for you. So the same case, as you keep doing, you just stop there, and luckily that is the simple touch. It was side away. What you do is turn that, and you have enough space here. You do all the phaco here, rotate the nucleus towards that portion, and you can go ahead and do the surgery. And again here, you have to make sure that you respect the safe zone. Then using the second instruments to block the iris. See, if you go ahead, you can do that. And in this case, I am showing as a IA, but even in phaco also it does happen. So what you do is just take a Sinski hook there, keep it as a guard, and then you can go ahead and easily remove even the subincisional cortex. And sometimes if it's in the other side, like here, the iris will get stuck into it's a blessing in disguise in the side port. It's a blessing in disguise. You still can go ahead and do. And aspiration port, so you just have to make sure that the aspiration port is always away from the site which you have touched. The other iris parts will never come to you. It is only these portions which keep coming to you. So all the aspiration you do with the aspiration port away, with that you can go ahead and somehow manage. But in the very severe cases, you may have to use 1 or 2 hooks. Usually because the touch is on one side, you can use a single hook. But if you have a very small pupil, you can go for multiple hooks or a ring and go ahead and do. The base idea is respect the central safe zone and ensure all your fluidics and other parameters are within the central safe zone. By this, you should be able to ensure that even if you have a bad touch, one is obviously prevention. The other is if you have 1, 2, 3, plan A, plan B, plan C, which is going to help you out. Sreeni, can I do this next one? Yeah. I finished on time. Probably we can have some discussion after my second talk. The second talk is mine is a wound burn. Technically, wound burn is called corneal incision contracture. I'm sure all of you again would have at some point of time, but the pathology basically here is what happens is it's characterized by corneal tissue whitening, basically tissue contracture, wound gape, striae, and distortion. Here what happens when the temperature at the incision reaches 60 degrees, the burn is so fast, within the first 3 seconds it happens, and the incidence is very rare, of course. Now what is the cause? The cause, you have to understand what are the causes, mechanism. So mainly there is two sources of heat generation. One is during electric energy to mechanical, that is the piezoelectric, and the frictional heat when the vibrating phacoemulsification needle comes in contact with the sleeve. So the sleeve and the conversion of electrical, that is the heat generating part. So what actually happens is, everything goes well, you won't have a problem. Most of the time we feel that it is when you use high power, that is when you get, but that is the confounding factor. The main factor is either the irrigation is less or stopped, or the aspiration is blocked. So these are the two major first line things. The moment you have something there, if the irrigation is low or if the aspiration is blocked, that is when you have to make sure that, okay, now I may get a problem. So before you even proceed, you should ensure. The confounding factor is power, high power. High power is not the first cause. The first cause is irrigation, lower irrigation. What is the effect of thermal energy on the corneal layers? On the epithelium, it is no sequelae, it just causes coagulative negative. By next day you are normal. It is the stroma. The stroma, it causes irreversible contracture, and that is where we all end up in problems. Endothelium, obviously, it is only a cell loss. 1 or 2 days you will have some edema, few week, the adjacent cells will take over. So the problem is how you are going to manage the stroma. So as you said, dense cataract is a confounding factor. Type of settings, when you are using, nowadays most of us don't use continuous, but those of you are using now can switch over, especially if you are doing the divide and conquer, you could switch over to the hyperpulse or pulse or micropulse modes. That definitely, because it gives you the gap, the cooling gap in between, so that will help you. And make sure that you use excess additional phaco only on occlusion. Before and after you can avoid, so thereby you use less of the phaco power. And obviously mechanical techniques like chop will be of much help. So this is one other cause of sleeve compression. When I say when you have a sleeve compression here, if it is here, there is fluid passing through. The fluid should be passing in through the sleeve outside, and also should be aspirated. When the fluid is coming in and going out, the temperature is controlled. If either of them is blocked, so that is when you end up in wound heats. The other major cause is sometimes thermogenic, that is dispersive effect, especially when you use these viscoat, which are very high dense. They can go and block, and then you go ahead. Initially what you will have occlusion. Even without the tip getting occluded, you will have occlusion sounds coming. That is when you have to be careful. Or you may have this milky white sign, which indicates that, okay, there is a occlusion block. If you keep going ahead, that means the irrigation aspiration is blocked, the wound burn is going to happen. So be careful when you have white cloud signs, lens milk sign, leak incision, that is, you will have the bubbles there, and you will start seeing initially. You have only 3-4 seconds in case there is complete blockage of irrigation aspiration, and if you press it, within 3 seconds you will have the wound burn there. So that you have to be very careful. That is why you have to look for these signs. So what is the sequelae there? Usually it is manageable, especially in the hard cataracts, but if you really have it because of the blockage, then there will be fish mouthing, which is very important, because the wound, though it appears you are closed, will not close. That is where management becomes very important. Prevention is very important. First, test the fluid, test the inflow irrigation. Many times the irrigation water is over, you are doing the 3rd case, 4th case, water is over, you just go in, and that is when you get the wound burn. So check for it, see for the compression of the sleeves, use appropriate settings for the nuclear density. Unless otherwise required, don't go for the high settings, and avoid overfilling OVD. This is one thing that most of them, there are some people who actually go in, first aspirate the central part of the visco and then go ahead with the phaco per se. So that is a good technique, because sometimes we ourselves don't know what type of visco we are using, and many times we are going and keeping on filling with the, especially if you are using visco, that is very, you have to be careful. create a fluid pocket, aspirate the anterior cortex initially and the part of epinucleus, and once you see the nucleus, then you can go and do your trenching or your regular that way you're sure that there is free flow, there is no obstruction to the aspiration. And be alert to visible signs of decreased fluid flow. That is the Lenz-Milk sign. That is very important. That is one sign. And the other sign, important sign, is there is occlusion. Be careful about the ears, your music. Occlusion sign without the tip getting occluded. That means there is aspiration block. So that you have to be very careful. Treatment, most of them you can manage. Fish mouthing of the section is very important. Many times we overlook it. That is one of the causes for post-operative. So if you are not sure, you can do a Seidels test and you should suture. I have 1 minute time. Yeah, okay. Yeah. So you have to suture, and the suture technique also, many things have been described. I'll just go in brief about that. And if it is severe, we may need for some AIMT scleral patch graft or pericardium patch graft. Mostly we can manage with suturing and wound suturing with BCL. The only disadvantage at this point of view is high amount of post-operative astigmatism, that you have to be very careful. So most of us do put these radial sutures. In such cases, you have to be careful, recheck, because the radial sutures will not be sufficient, especially if there is fish mouthing. Some of them, what they suggest is use the anterior the roof and directly to that. Don't involve the posterior, because our problem is the fish mouthing. So to avoid, because you just put a radial suture, the fish mouthing will not be solved. So one is that. The other is use a compressional suture, horizontal mattress suture. So one radial suture and one horizontal suture. That's the mattress suture. If I have time, I'll just go through this. And most of us now, with the advent of BCL and cyanoacrylate glue, we are managing with that, but it takes a long time. Post-operative sequelae will be, you have to keep in mind those things in mind. The other is, there is a conjunctival flap. Use a double-armed 10-0. Go through the superior, the conjunctiva from one arm. The other is from this side into the sclera, and then you just tie. It goes below, and the wound is nicely covered. This is in case you have fish mouthing where it is not closing, and there is a nice burn with corneal contracture, the stromal contracture. And obviously, in severe cases, we can go for very rare scleral cancer, but these are there theoretically. We can look into it, very rare. And autologous Tenon's plug also is there. The same thing, you just go and plug, it gets healed very well. But with the advent of cyanoacrylate, this becomes glue, this becomes obsolete. And pericardium, I don't think anybody has done. That's basically for theoretical purposes. Thank you, Dr. Sreeni. Anything in discussions we can have later.
Thank you, Mish. We will do the discussions at the end, so you can. Next we'll have Dr. Arup Baumik, who is probably the one of the highest volume, high quality phaco surgeons in India, and so we'll be speaking on two topics: IOL implantation mistakes.
Good morning. Thank you, Sreeni, for including me in your IC. This presentation is regarding the IOL mishap. So you implanted a wrong IOL. What to do now? This is my topic. Or you implanted a IOL and the patient having some problem. You have to explant the IOL. So how to explant the IOL and implant the new one or correct one? So there is a lot of IOL cutter is available in the market. One is a short bed, which is made by the Cartina. It's very costly, and this model, the newer model, this model is basically Rumex model, double hinge, but it is also costly, but it can available if you any friend go to ACRS. Now Epsilon also marketing. The one company from Ukraine is making this copy, and this is probably the cheaper one, and it will get in the 20,000 rupees. Otherwise, for Rumex it is almost 60,000, and you MST or Cartina, you know, it's almost all the instrument is you have to spend 60,000 at least. So whatever instrument you have, you stick to one. So you develop one technique, stick to one, but sometimes you need the different the cutter, but you stick to one. And I am showing this is my snare technique which I developed 2009, which I explained the IOL, how to explain the IOL. So this is how the mishap happened. This is I am implanting under irrigation, so this is a mini oil proxa lens, and suddenly it got stuck, and the lens haptic was so long, and it is a hydrophilic lens. It got stuck. I cannot inject then I injected OVD from the left hand side port, but I am not able to implant the lens, and there is a struggle. So I thought I should snip little bit relaxing incision above the top of the injector. So even then I top up the injector, but it is not going down or not releasing. Even then it is not releasing, and the haptic is badly stuck in the. Then I cut the tip of the injector. See, cut that so that I can manage this. But even then I remove the plunger, and when I implant the lens, I saw I have damaged the one haptic. And you know, the mini oil proxa, it's a one kind of trifocal lens, basically EDOF lens. You need to have a centration absolutely. So I decided to expand the IOL and put a new one. So as I showed you the Rumex model, I used the Rumex model. This is a fantastic cutter, and it cut like a cheese. It cut like a IOL, like a cheese. So it is a nice one, and it is now available. If you order Epsilon, they can make it. It is made in Ukraine, and it is they have to bought this. This is very good. The steel quality, hinge quality is nice one. So next case, this is a case again. I am showing this same cutter. This is a wrong eye line implanted. It is not a toric calculation. It's a toric calculation. Patient having severe problem. This is another way to go. You remove the pi, just pi, because the optic size is 6 millimeter. If you remove one pi, then you somehow manage, because the half will be the 3 millimeter. So if you make a 3 millimeter, then you can easily able to rotate and able to. This is a holder. It's come with the same cutter system. I pulling the one haptic, and you see this a little bit increase, because it is a 2.6 incision. I make a 3, and now it just pull and now rotate, and you can easily remove. So either you have to make it as a 3. Either it is a make a pi, remove a pi, or it is bisect the lens. And the third one, this is a wrong IOL. I understand after implanting my OT assistant, this is absolutely wrong power. So I do the IOL scaffold. If it's a good technique, if you really identify one, immediately it is a good technique. And here I am using my snare technique, which is made of prolene, but you can make it with Greta string also. That's a snare with the 22 gauge needle. So I just increase a little bit of the incision, 3.2, and this is a prolene snare which I made. It is available in my OT, because my OT assistant made this. I made this 2010, and it's that video got the ACRS Grand Prize in 2010. And you introduce into the loop, and I cut the both side of the Monarch cartridge so that it open the mouth. It is a Monarch A cartridge, Alcon cartridge. Now I am pulling the snare, but unfortunately this device is not available in market. You can see now the cartridge, the both side is open. It is open and now engulf the whole lens, and it's come out with the same process. So thank you so much for the kind attention. I'm always advise you stick to one type of cutter. It is stick to one type of cutter. There is a lot of cutter available in the market, but frankly speaking, Indian companies are not, because of the hinge or the quality of steel, that cutter is not good. And if you buy one Rumex or the Rumex modified one that's make in the Ukraine, it will goes at least 5 to 7 years. So go to invest. It is worth investing in the cutter.
You're absolutely right, sir. Like you try with the Indian cutters, it just keep tilting.
It is slip. It is flip. So because of the hinge quality is not good. Even the steel quality is good, but the hinge quality is not good.
So go for your next presentation on DM detachment.
Yeah. Thank you so much giving me another topic, Desmet detachment, noted in the table, or post-operatively what to do. It's why it is happened. It happened during any instrumentation, except few cases it can happen spontaneously, like PPMD. Otherwise, this can happen spontaneously. You can see the patient is absolutely fine. Next 2 days, there is a total Desmet detachment. So this is a case in the 6 post-op days come with a corneal edema, and you can see that all are good. Corneal, central circular oil in place, healthy, and I did not notice any kind of, this is my case, I didn't notice any kind of extra energy. I used this case because the lens, the cataract was just NS3. So now the slit lamp, I can till that slit lamp I can make out that there is a Desmet detachment. So what to do next? And I do the anterior OCT, and this is a vertical section, and you should go for the vertical and horizontal to see the extent of the Desmet detachment, because you need to inject air, you need to clear cornea. So you have to define the Desmet area, detachment area. So this is the ultimate result of this OCT, and I make a side port, because the vertical one are not very extended, so I put the air. This we call the power of air, that all the endothelial surgery is basically it's depend on the power of air. You go for DME, or you go for DSEC, or you repair the Desmet detachment. This is the power. You make it's absolutely tight, make it tight, and make a bubble and make it tight. If you make it very tight, wait for 30 minutes, then you can release some amount of air. So after 4 hours, this is absolutely clear cornea, and the Desmet is absolutely attached. And after 6 days, you can see this is the figure. So you have to diagnose that in time, because if you neglect this case, there is a inflammation in the Desmet, and the Desmet will be taut. Once the Desmet will be taut, then it is very difficult to reattach it. So then you have to do the desmetoplexy. You have to release, keep some incision in the Desmet to release this. So you can see this, some cases it's become absolutely taut. If it is like modulating, it is easy, it can settle with the air. So it is not described in 1928, it is not new, but total and central delivery good talk. But yes, it can happen. The blunt blade, phaco probe, hydration or spontaneous. As I said, only the case of PPMD, it can spontaneously have, even after uneventful phaco, after 3 days there can be a total detachment. This is also my case. Just observe this case. What I make a mistake. When I hydrated the second port, there is a descent detachment probably here, but I missed it. Again, I going for the hydration, keep hydrating, and I just hold it descent detachment. So when you miss the earliest sign of the descent detachment, keep injecting fluid, it will increase. What to do? So next step, I identify into the OT, and the next step, I put air. So whenever descent detachment is, you can see this. Understand that air bubble should not be go within the this is a very important step. If sometimes it goes, you try to make a reattach and put a air, and air goes in the cornea and the descent, and there will be the total descent detachment. It will be careful. You make a clear corneal entry. So this is a case by Dr. Bosak. You can see this. With the hydration, there is a little bit detachment. You can see this here. Again, he just missed probably. Now it is a descent detachment. So this can happen during surgery. Then you should go for the total air tamponade. So what to next? Just put air, make a tamponade, keep it. You need it. Suture the incision, keep it tight, and the next day it will be fine. Within 2 to 3 days it will be fine. Here it's putting the air probably in the yes, and probably in between the cornea and the descent. So you can see it's like a big bubble of the dull. So again you make a separate incision, you remove the air from the in between descent and the cornea, and so yes, now the air from the descent and the cornea is removed. Put more air. It should be a single big bubble. Single big bubble means you are in a right place. This is the result, and I am not going for. This is a case referred to me. The surgeon started surgery. There is total descent detachment. He identified. He abandoned the surgery. Unfortunately, patient came 7 days late. There is a corneal edema, so I have to remove all the corneal epithelium. So because if you continue at the early stage of the surgery, if there is a descent detachment, if you continue the surgery, you can damage the descent. There will be the descent removal, or there will be descent tear. In that case, if it is a descent tear, it's a very difficult to manage. Then you have to go for either demake or desec operation and make a tunnel, and after that you can say just 1 minute more. This you can see this is a case NS3 cataract, descent is well settled, and after 1 month you can take up the surgery. Thank you so much for kind.
I'll go next.
Dr. Bhanati, you want to comment? It's your subject.
Taking all the discussions together at the end, let's finish the talks.
Running short.
Very nice videos, I think, all the presenters.
Wonderful presentation, sir. Thank you, sir. Everyone sort of going in for topical anesthesia surgeries these days. So a patient turning uncooperative, making the surgery difficult in this situation can be because of many reasons. See, intrinsically the patient is uncooperative. He's not able to fixate the eye. Or the patient, despite the topical anesthesia, patient is perceiving some pain there. Or the patient turns claustrophobic, or the patient develops some amount of breathlessness midway through the surgery. So this is one case. Speculum could be put cooperative for speculum, and after that the eye is not quite at all. It's moving around everywhere. So still, I thought I can continue with the surgery, start the surgery. So the side port and the clear corneal section were made. So even after that, the eye is not quite. So it's moving all around. It's going out of the field. Still, thought I can continue somehow. Put the trypan blue. Washed it. Put visco. See, at the, by this stage, you have to leave your ego there. So there is no point in continuing like this. So what I did was made a nick in the infranasal quadrant, a small nick about 5 millimeter from the limbus through the conjunctiva and the tenons. So went in with that went cannula. So it is going smoothly inside. So it's in the subtenon space. It's on a 2 cc syringe with xylocaine in it. Injected. So immediately after injection, so it won't take much time, the analgesia sets in. See, the echinacea takes some more time, but you can see I mean, it's sort of come down the movements. So with this amount of movement, you can easily continue with the surgery. So still a little bit of movement. The echinacea takes a bit more of time. Either you wait for it to happen, or you can continue with the surgery. So the rhexis was done. After that, everything was okay. So the Steenen capsule is in close opposition to the conjunctiva and fuses at the level of the limbus. And the subtenon space is a potential space between the Steenen's capsule and the sclera. So the idea is to go about 5 millimeter in the infranasal area and make the nick through the conjunctiva and the tenons. And insert the cannula, the subtenon space, and it should not be in the subconjunctival space. So once again, so the nick is made. See, the cannula goes in hugging the sclera. So if it going in smoothly, it is in the subtenon space. If it gets stuck, it's in the subconjunctival space. Don't keep poking. Make another nick and do it. So I inject about 2 to 2.5 ml of xylocaine. See, there are different models of the subtenon's cannula, different gauges, 21, 22, 23, end opening, side opening, all work. See, I have, I'm not sure what my nurse gives, but all works. So the only complication that is possible with this some degree of subconjunctival hemorrhage, and that results in no time. Claustrophobia. See, this is the most scary one. Like I've burned my fingers a few times. So if the patient is claustrophobic, I don't start the surgery, because the patient never would have slept with the blanket on, so he doesn't know that he has a problem. And now once the towel is on, he can't cooperate. So don't do it. Assess. There is a 8-point tool to detect and manage claustrophobia. A detailed history claustrophobic questionnaire is there online. counsel, see what are the anxiety provoking factors. You can actually take the patient into the preparation room, give him a trial run, put a towel and tell him that this is what you can expect. So educate him, give him the choice of all other options, including general anesthesia. Intraoperatively, if the nurse is there holding his hand, that calms him down. The second surgery, second time the patient is taken into the OT, it has to be done by a senior surgeon, experienced surgeon, who can do the surgery fast. The surgeon can keep talking to the patient. The drape can be, I mean, obviously everyone will have it, that circular one. It should be dented so that he gets some space there. And the other one is the patient coughing on table. So, see, that is pulmonary edema. Nothing just starts coughing. Just stop where you are, midway through the phaco, or even small bit is remaining. Just close it, take him out, check if there is pulmonary edema, give IV mantol, and transfer to the physician. So this is basically on the next presentation. Yeah. Okay. So this is another scary situation. You have posted 25 cases for surgery today. So before entering the OT, the cases, few cases done on the previous day or just a day before that, comes with this severe inflammation. So what do? You have 25 cases posted for that day. It is a red alert situation. You postpone all the cases. You can tell them whatever you want. The surgeon is sick or the machine has conked off, but you're not going to do those cases. Just postpone them. But what to do with those other 40 cases that were done on the previous day? You call them up, inquire if they're comfortable. Any discomfort as such, you call them back to the hospital. Make sure that they don't come at the same time. Give them different times because otherwise it'll be a very scary situation. Then assess. Now you have to distinguish whether it is TAS or it is endophthalmitis. So in TAS, even in TAS, there may be hypopyon. Obviously, there will be severe AC cells, but the congestion doesn't correspond to the AC reaction. Normally, these people don't have pain unless the IOP is very high, and normally they don't have chemosis or lid edema. AVF cells won't be there. If it is a severe TAS, the pupil will be dilated and fixed. IOP would be very high. See, you should analyze if you have been seeing more cells than normally what you have on the first post-operative day, then that could suggest a TAS, and these cases will have a limbus to limbus corneal edema. Endophthalmitis, usually they have pain. Congestion is severe. Normally chemosis and lid edema would be there. Pupil not dilated, normal or constricted. IOP is not very high. Corneal edema won't be there. Even in these cases, they might not have hypopyon. AVF cells will be there. You do B scan, even if it is anechoic, it doesn't mean that it is not endophthalmitis. So what next? Admit these cases. See, if it is very severe, we suspect something like pseudomonas, don't do this. But if it is somewhere in between, you can give a trial of topical and systemic steroids, assess how early. If it is improving and not worsening, it probably suggests TAS. But if it is a severe inflammation, because pseudomonas endophthalmitis, in minutes the cornea starts melting. So you can't wait in those cases. In the cases which are worsening, take a vitreous tab, give intravitreal antibiotics. and refer to the retinal surgeon before, because they need a clear cornea to manage. It requires an early vitrectomy in these cases. So refer it at the earliest. So what next? You review all protocols. If possible, form an expert team, including everyone, ophthalmologist, hospital management, microbiologist, epidemiologist, OT, nursing staff. Take cultures from the operation theater. Note the batch numbers of all solutions used and send samples for culture. Keep all solutions in safe custody. Review the surgical log and individual surgical notes. You have to inform the authorities, your hospital authorities, and if it is the camp thing, you have to inform the NPCB. This is also very important. Inform AIOS, IMA, your state society, the local medical persons. And this is very crucial. See, you might be able to manage somehow, but once it goes to the press and you get a bad press, that ends it. So it'll be sort of it'll develop suicidal tendencies at that time. So this is very crucial. It is ideal that it's not the surgeon who deals with the press. You have to have your legal. See, in Kerala, we have a wonderful IMA support system. So they take care of it. AIOS has a legal cell, alerting colleagues, talking to your colleagues for your support, report the cases, and media. So that's what I'm talking. Media, handling the media is extremely crucial, and that is where the whole hand management skill lies. So let's hope that something like this doesn't happen to anybody, and you become more and more pious as you do more and more surgeries. Thank you. And next, Dr. Umesh will be speaking on postoperative refractory surprise.
Yeah, thank you, Professor Vanati. It was her talk. I'm sure all of us have faced this. Very common for us. Most of us have seen postoperative surprises. And so most of us, when we do monofocal, easy to manage. Usually it is plus 1 or up to 2. It is easy to manage, especially if it is the minus side. Patients also don't complain because they have very good near vision, so most of them don't complain. The problem occurs is once you cross the 2 diopter, 3 diopter range, especially if you are on the hyperopic side. That is when the patients create much of an issue. So though very uncommon nowadays with the advance of good biometries, source biometries and all those things, we do see across. And those who are practicing premium IOLs, especially torics, though up to 1 diopter is acceptable, 92% plus minus, in the higher power of, if you are operating on the higher power of toric IOLs, leftover of 1 is acceptable. Most of them are okay. Out of 4, if 1 is leftover, you don't mind. But if you are operating only on 2 diopters, 1.5 diopter, that is when the problem occurs. Then what shall we do there? So obviously you have to look at the detailed history, especially if the patient, you have put a multifocal, ask for visual complaints like clarity, halos and glare. And if there is a overcorrection, undercorrection with intense glare, halos, if it's a multifocal, I think it's better you explant it. You look for manifest refraction, intermediate and near, complete slit lamp obviously. That is to make sure that you don't have a problem in multifocal lenses. Monofocal lens, what are the options available? Yes, spectacles, contact lens, most of the older people don't do, that's an option available, but at least I try maximum myself to ensure that they are happy with the spectacles up to 2-3 diopters. If it is on the minus side, I somehow manage to counsel them and say them it's good for you, your reading is good, blah blah blah. Most of them are convinced, Those who are not convinced, I have a couple of options. One is either IOL exchange or a corneal refractive surgery, that is for monofocals. Multifocal IOLs, invariably dioptics was seen in the past. That is, if you have any correction, do a refractive surgery. But if the patient is not happy, the IOL exchange is the only option for multifocal. Though nowadays with the advent of the newer EDOF lenses and all, the incidence has come down. But in the older days, we did have a couple of cases where we had to do some explantations. Toric IOLs, yes, very common. 3.3 for every degree of misalignment, you will get 3.3% of the intended correction loss. So more than 30 degrees, everything is lost. So you have to do that. We'll go one by one. If it is a toric IOL, what we do is, within earlier the better. We have online calculators for that, both astigmatifix.com and Barrett transform formulae. You just have to go to the online calculator and put, you will get the readings. You have to do that. A simple off trick is, what I do is, third day or first week post-op, see if there is significant change in the intended axis. I just do a AK and see what is the steep axis and rotate it on the steep axis. Most of it will be done. And invariably, what that and the astigmatic outcome, what it recommends more or less will be the same. That is what I have observed. 1 degree this way, that way, a couple of degrees this way, that way. But as a personal experience, you can take a call. Invariably, they all do very well. This is one such case where I had a -3 post-operatively. It was supposed to put at 167 degrees. This was the chart I got from the company. We went ahead and put post-op. I had -2 residual. -3 is the cylinder. I got -2. The IOL rotated around 16 degrees. 16 degrees. So the intended was 166. We went and did a toric lens. It gave the same thing, around 16 degrees. The axis also, post-op AK showed 167, so 170 degrees, so more or less there. We went and did a re-rotation, and post-op cylinder we got 6.6. So it's relatively easier for us to handle post-op toric IOLs because we have these new formulas. In IOL exchange, we do when we mainly, the main is wrong IOL power insertion, and that invariably happens many times. I think Arup has done an extremely good job in showing how to remove those IOL exchanges. I will not go much into it. Two major indications for IOL exchange as per IC is multifocal lens, where they have gross dysphotopsias and wrong power inserted. Even multifocal nowadays is come down. I think wrong IOL power, this very commonly happens, may not be in small practices, but in big, who have a big list. You end up inputting one IOL for the patient, the other. It normally happens, so be careful. The best is to have multiple checkpoints where you ensure that wrong IOL doesn't happen. But if it happens, Dr. Arup has shown beautifully. I have some videos, but Arup has shown very beautifully how to cut. Essentially, you have a complete cut, a partial cut and rotate, and a pie cut, and beautifully shown by Dr. Arup, and rotate and remove. So I will not go much into it. And emphasis, yes, emphasis on the type of cutting instrument, the forceps that you need to do. Piggyback IOL, off late, Sulcoflex is there. I have used in a couple of cases, but only if there are in some cases where you do have hyperopic correction where you don't have power. For example, in this case, I had put a multifocal lens for 34, beyond that it's not available. Then I went in for an additional correction. Here I put a IPCL, the ICL. Luckily that was a hydrophobic lens, and this is a hydrophilic lens. So generally they say that don't put the same materials because of interface opacification. It did work out for me. Some of them are opting for piggyback ICL or IPCL as one alternative if they have, and it does work well. Otherwise Sulcoflex is there. It's very easy, you can just go ahead. Indications is when you have a PC rent, you have some zonular dialysis, you can't remove the previous IOL for some reason, then piggyback IOL is indicated. Maybe very, very rare, but If you have such situations, I think one option is always there for you. You can consider limbal relaxing incisions nowadays, not much. Corneal refractive surgery, yes, as a LASIK surgeon we do. In cases where I think up to 4 diopters, less than 4 diopters, I consider refractive surgeries. Usually I wait for 6 weeks, the more the better, because the stabilization occurs. Multifocals I have never done, but dioptics was a thing of the past. Nowadays not much. What you should be careful is limitations. In this age group, you have to be very careful about dry eye, surface abnormalities, and I plan for a slight undercorrection. I don't want to do emetropia, slight undercorrection 0.5. So here is a case where the patient, one patient, the other eye I had done, this is an ACIOL, he had a -4 residual, the other eye we had emetropia. So he wanted correction on this eye, was long back, ACIOL. I think PRK surface ablation easiest. If you have some facility, even any one of you can go ahead and do, just scrape the epithelium, go ahead and do, and patients are invariably very happy. Only thing is, make sure that the pupil is round so that you don't have dysphotosia post-op. The patient was doing quite well there. That is for patient with ACIOL. And this was one pseudophakic patient. I had a long IOL insertion. I went ahead and did a LASIK. He had -4, not willing for IOL explantation. So went ahead and did LASIK. Complain, see these patients complain of dry eye post-op, manage them, number 1. 2 is slightly undercorrect. Don't do, if you're, say for example, if a young patient you're doing 4 and you're correcting completely 4 here, you don't need to correct 4, you do correct 3.5 or something, make him slightly myopic 0.25, 0.5, because sometimes they have a tendency to overcorrect, and if it goes to the plus side, again it is going to be a problem to you. Myopia is easier to manage than hyperopia. And
Umesh.
you're done, okay. Thank you. Discussions we can have.
Next, I invite Dr. Gopal Pillai to speak on suboptimal postoperative best-corrected visual without any obvious reason.
Thank you very much, Dr.Sreeni. These are a set of very, very common problems that will occur to any practicing cataract surgeon, and I congratulate him for bringing all these in here. So, what if we operated one case, we finished it, and next day when we saw everything is looking all right, but the vision is not there. A suboptimal visual recovery after a clean case with no obvious reasons. So in this presentation, we will look through what are the reasons, what can be done for such conditions, how to counsel the patients, and documentation is very important because tomorrow this may lead to a legal angle. So we can look at preoperative causes, intraoperative causes, and postoperative causes. See, in many of these patients where there is no obvious reason, probably if you dilate, if you look inside, there may be subtle findings which can lead to a problem. So first thing, preoperative evaluation, what is most important is the cataract, the amount of cataract commensurate with the visual loss? That is a very important question that you need to answer. See, when you are in a high volume setup where any cataract would come, you pick some people up and then, have an axial length keratometry, get an IOL power calculation, put it. But this is very important that, is the amount of cataract commensurate with vision loss. You can evaluate cataract through a slit lamp or through a distant direct ophthalmoscopy. You look at a dilated image of the lens and then do that. Was it a very mature white cataract with poor vision to start with, and you operated and you expected good visual recovery? So that is again another problem. Always check the pupillary reflex, because pupillary reflex is one examination technique which can rapidly tell us the integrity of the posterior segment. Is the retina and optic nerve normal? In an undilated case also, you can consider looking the optic nerve and the retina with a 90 diopter examination. Are there any large floaters? See, many patients with cataract may have floaters as well. And when the patient has early cataract and a lot of floaters, one may consider that removing the cataract surgery, the floaters still remain. Any preoperative history of stroke or neurodegeneration. So if there was any stroke and there was a sudden drop in vision, even after removal of the cataract, that sudden drop in vision due to stroke will not go away. Due to preoperative pathologies like high astigmatism or glaucoma and glaucomatous optic disc changes, floaters, pre-existing retinal and macular pathology, which may be subtle, like an old vascular block, you may not come to know after 10 years or 15 years. An old AION may look as a pallor of the optic nerve a little bit. So optic nerve pathology, CNS ischemia, all these are reasons. Intraoperatively, sometimes a block perforation can occur, and there are three ways of having that. One is that you go in, you understand that you went in, the doctor understands that. Number two is, without understanding, you inject inside the globe. And number three is, the surgeon does not realize that he has gone in, and the surgeon does not realize he's gone out, and inject in the correct plane. And here, the block would be almost normal, the patient would be fine, but there would be bleed or retinal detachment or choroidal detachment or something like that later. IOL, wrongly powered IOL, now Umesh just now told us about that. IOL decentrations. Intraoperatively, when you put in, it was good, but probably by the next day, there was a decentration. Intraoperative AION. When the pressures are held very high to maintain the anterior chamber, in susceptible discs, like for example a diabetic disc, a brittle diabetic with a nephropathy, or even a glaucomatous disc, what can happen is that final few fibers can just go off with an intraoperative AION. Intraoperative vascular block can occur whenever the pressures are very high during when you are massaging after a block, or during heightened bottle. Intraoperative choroidal detachment or suprachoroidal hemorrhage, which on a posterior pole examination you may miss also. Vitreous hemorrhage and suturing, tight suturing, etc. Post-operatively, you could have a choroidal detachment, and the choroidal detachment can actually cause PR inaccuracy as well. So here is a case where in the posterior pole examination you may not find anything, but a choroidal detachment may be there in the periphery. Delayed suprachoroidal hemorrhage can actually push the lens iris diaphragm anteriorly and cause problem. High IOP, malignant glaucoma, all these are not unobvious, but sometimes in the first postoperative day or so, you may not always check the pressure. Some people do not check the pressure, especially in a high volume setup. Early endophthalmitis, Sreeni told us about reaction which can occur, vascular block and AION. Now, delayed postoperatively, decentered or dislocated. Okay, all right. So, PCO, PVD, vitreous hemorrhage, CME. CME is another important reason. What can be done? Preoperative problems like astigmatism, you may need to treat that with keratotomies. Glaucoma, obviously management is to be done. Floaters, if there's troublesome floaters, we can do a vitrectomy, etc. Intraoperative, all these have wrong IOL power and IOL decentrations. We have already seen how they are managed. Intraoperative AION, at least try to prevent it by not increasing the pressure so high. Intraoperative vascular block also similarly like that. So post-op problems, high IOP, malignant glaucoma, obviously you may have to treat it, and choroidal hemorrhage, yes, a retinal surgeon needs to be coming in. Delayed post-operative problems also have their own management. It's always imperative to counsel these patients. Post-operative pathologies, endophthalmitis, IOL-related problems, all these can occur, and always document this. Each patient is a potential court case, and document pre-operative, post-operative vision and findings. Thank you very much.
He'll finish in 2 minutes. Dr. Kaushik is going to speak on how to manage the unhappy patient.
Thank you so much, Sreeni. I think this has become like a yearly pilgrimage for us. Brilliant surgeons may come up with brilliant surgeries, but you may still have patients like this. So this is a 58-year-old who's worked as a purchase manager in a hospital. So the assumption is he knows something about cataract, something about IOL. He's a diabetic on control, and he's had blurred vision for 6 months. So he lands up in our clinic, and he's told by the doctor, you have a cataract. Now in his mind, he's got questions of how long is the recovery, when can I travel, do I need to wear glasses, what can I do? So the doctor very clearly, and this happens in almost all our clinics, where we say that after surgery, you will see very clear, don't worry with glasses. Do you have any questions? Otherwise, my counselor will guide you. The patient is overwhelmed. because he's been told he has a surgery and he needs to get it done, and he says, perfect doctor, no problem, I've understood everything, and he walks away from the clinic. Now he lands up with a counselor. This typically happens in large practices where the counselor is telling him what are all the options that are there. They tell them you can have topical, you can have block, Indian, imported, single piece, toric, whether you want faster recovery, small incision, large incision, there are other options. But then we think that this particular IOL will suit you. The patient is completely confused. He is overwhelmed with the amount of information that is landing into his head. Now he has taken a leap of faith and he's decided to get a surgery done. And then he Googles up the hospital name and he reads a report where he finds that there's a report of a particular IOL that the hospital has used, and they found that there are better incomes. And then he's sitting in the block room and he notices that the person next to him has got that same box that has a label that he read in the paper, but his label is not the same. Now he's a little confused, saying that they've said that this particular lens is very good, but why is it that I have a different color lens? He anyway gets his surgery done. He's reading 6/6 on the first post-operative day. The surgery was perfectly okay. The quality of care was perfect. He has no complaints at all, but he's got some doubts in his mind. So this is something that does happen. Often as surgeons, we may not be aware about it, but talk to your staff. There will be many a patient that happens every year. When an unhappy patient happens, this is something that the psychologists use for surgeries. Largely it's been used in aesthetic surgery. It's a mnemonic called BLAST, which says that believe, listen, apologize, satisfy, and thank. So first you need to believe that the patient has a problem. So you approach him, you tell him saying that I believe you're unhappy and I want to understand what happened, because often there is a miscommunication that's happened. Next is you need to listen. And listening is active listening, where you're not looking at your phone or you're looking at the computer doing an entry, but actually having an eye contact with the patient, nodding your head to appear that you are understanding, and you paraphrase saying that I understand what you're saying is very frustrating and that you were not told about the IOL options or why this particular IOL was told to you. Then you have to apologize. In our business, the patient is always right. There are no two qualms about it. I apologize that you are upset about us not reiterating the options and just handing over a sheet of paper that said what IOL and what estimate, and then go on to explain saying why the judgment was done. It's not too late to salvage it. For your condition, you're a diabetic, so the other lenses were possibly not useful because your contrast would have dropped. Therefore, we thought the monofocal is the best, and we think in the long term this is going to do something very good for you. Anyway, you can see very happy. You've been used to wearing progressive glasses, so there's going to be no problem for it. And at this point in time, we thank him saying that, okay, we hope that you've got all your answers. And we were in the process at this point in time of working with Microsoft and building a chatbot, and we kind of handed it over to this patient. So today, PREMs are something that are becoming in vogue. So you will see with accreditation that this comes in more and more into practice. These essentially are tools or instruments that look at the satisfaction rate that capture it from the patient's point of view. So typically it will have questions like, were you informed about your eye condition and the expected improvement? Were you informed about the various options that you had? Did the staff inform you about the cost of treatment? Were you explained about the surgical procedure before you actually signed the consent? So these actually tell you how adherent the staff are to our SOPs, and this kind of adds some method to that madness and make sure that what we intend to do is actually getting done. Knowledge, we assume that the patient knows because we've told them, the counselors told them, they've signed a consent form, but we need to understand that there is a possibility that they could be misinformed by the staff. They may be told that you will be completely glass-free while you're using an EDOF, where 80% of their activities, possibly they're going to be glass-free. They may have a misperception because they've been told by their friend that once they got the surgery done, their vision was brilliant, but they don't realize that they have a retinal pathology that may not allow them to have that same kind of an outcome. And of course, only about 37% of them in various studies have been shown to retain whatever information that they have. So what we've done is we've deployed this bot in our hospital and we've kind of validated it now. This shows the point of view of the patient and of the surgeon. This runs on WhatsApp. This is a GPT-4 based application where the patient is provided this solution from the time they counsel for surgery and until 1 week post-operatively. So they put in a question almost instantaneously in a few seconds. Currently we use an open key, so it takes about 7 to 8 seconds. They get an answer with a question mark. This is what the bot has generated based on our curated knowledge base. The same question comes to the doctor. He can then validate saying that the answer is correct. The minute they type yes, you will see the question mark turn green there. So the patient is thrilled to bits about his answer coming and it getting validated. Uh, so what we've realized over time is that only about 55% of patients are known to have discussed IOL options. They just go by what they're told. And 75%, despite being told, understand what they have to be done. So it is very, very important that the content that we deliver is more related to the patient and we kind of understand what their expectations are. Otherwise, this imbalance is bound to be there. So these are again some of the questions that came up and what answers that the bot generated. Again, the brilliant surgeons have showcased what surgeries are done. For the surgeon, this may be one among the list of surgeries that they do in the day. But I think it is very important for us to humanize it and not treat our patients as a cataract case and remember that it may be their first and only surgery that they will undertake in their life. So thank you so much again, Sreeni, for making us part of this IC.
Yeah, wonderful, wonderful. Sorry, thank you, Kudlu sir, for overshooting by 2 minutes. Yeah. Sir, we'll have it.
प्लग दे दो ये प्लग दे दो छोटा छोटा वाला प्लग दे दो